Hey, why don't we go ahead and get started? So, hello, everyone. Welcome to Ask the Grant Writing Expert. I'm Dr. Meg Bouvier. You know me as the creator of your library of NIH grantsmanship courses. I have over 35 years of experience as a grantee at NIH, a staff writer, and now a full-time mentor in for NIH grant applicants. And I'm here to answer your grant writing questions. So grab a cup of coffee and let's get started. So for those who are uh, watching this live, it is June 19th, and I will say that everything is true to the best of our knowledge as of today. If you're watching this as a recording, this is a disclaimer that you probably, things are moving especially quickly at NIH right now. So you want to just double check the information that I'm giving you today to make sure it is still accurate. What you should be viewing in the library right now, I would say that if you're targeting a fall deadline, October or November, I would say that you're probably in the R series, you're probably watching chapters 1 and 2 of Master the R series, or maybe you're watching the boot camp recordings for those two chapters, which are fully up to date. I update those slide decks every single time I give the boot camp. So there's, up to date information about, the budget and the new administration and new samples, et cetera. Any NIH updates? Gosh, I mean, the only one that I have seen that has caught my eye is this issue of the de-emphasis of animal-only studies. But I literally got this about 2 hours ago, and I have not had time to dig into it, so I'm reluctant to say anything about it, especially because it was not an NIH-issued notice. It was something that I saw a colleague sent me from drugdiscoverytrends.com. And somebody else said it was an NIH announcement made during a training. So two people have told me about this, but I have not had time to dig into it. So I'm reluctant to say anything about it because I don't want to fearmonger, and it is just inconceivable that NIH would not allow people to work in preclinical models. So we will see what happens with that, but I'll have more to report on that at the next AGE. Um, let's see. The other thing that I wanted to say, and there's somebody had issued a question, so I'll be answering that probably first. But the other thing is, I just wanted to ask if there are any people out there who have found that their membership was useful in landing a grant application at NIH or elsewhere. And if you are a person who fits that category, we'd love to hear from you. So feel free to reach out to us at meg@bouviergrant.com. And yeah, we'd love to hear about that. So I see that there's a question in the Q&A box. People can start to load their questions in there. And as I said, there's a mail-in one as well. So there's one from an attendee and one mail-in. It seems like the new scoring system really emphasizes innovation significance. Could you talk more about getting your grant to the correct study section? For our TBI project, we always ended up in ANIE study section and really got hammered on the significance in particular. We requested different study sections many times, but we're never allowed to move the grant. Okay, so there's a lot of pieces to this. So let's take them one at a time. So the first piece is, does the new scoring system really emphasize innovation/significance? So, and I think I got this question once before, but maybe it was in boot camp. I can't remember. But the new scoring criteria, well, let's talk about the old scoring criteria first. So you're all familiar with the fact that you got 5 individually scored criteria. So it was significance and innovation were separate scored criteria: approach, investigators, and environment. So there were 5 separately scored criteria. Under the new system, significance and innovation are mushed together into factor 1. So you get a single score for significance and innovation. Then factor 2 is essentially the approach. You get a single score for that. And then factor 3 is, I forget what they call it now, but it's essentially investigators and environment mushed together, but you don't get an individual score for that. It's considered in the review, but you're not going to get a numeric score for that. So instead of getting 5 scores, you're going to get 2. Okay. So 2 individually scored criteria. So does it emphasize innovation and significance? Well, first of all, it remains to be seen, right? Because we don't yet have or at least I have not seen any summary statements in the new system. I'm still seeing summary statements from the old system, but we should be getting those relatively soon. So we'll have a better sense then. So you're asking me, I think, to guess, right? And my guess is that this is not the case, right? Particularly where innovation is concerned. I feel that if anything in the new scoring criteria, innovation is probably the most significant change, to my mind, is that innovation is somewhat de-emphasized because now there's it used to be that there would be this conundrum in the old system where, let's say you were doing a study and you were using the most appropriate technique, but it was a tried and true technique. It was not something splashy and innovative. But it was the most appropriate thing to use. You could theoretically get marked down on innovation for doing that. Whereas in the new scoring criteria, that might not be the case. And I'm going to see if I can pull up the exact language. Let's see. NIH scoring criteria factor 1 so that I can get the exact. Here we go. Evaluate the extent to which innovation influences the importance of undertaking the proposed research. So the very first question is basically, is innovation of the techniques even relevant in this circumstance? And in some instances, the answer is going to be nope, it's not, because they're using the most appropriate methodology, but it's not something new and innovative. So, of course, having said that, if you can't convince reviewers of the significance of the project, so like factor 1 is importance of the research. If you can't convince reviewers of the importance of the research, it's a non-starter, right? But that's always been the case. I don't know that that's something new. The other thing is that historically, when there were 5 individually scored criteria, statistically, approach was the worst score on people's applications. And I would imagine that that's still going to be the case, right? That's the area that reviewers are really going to focus their energy on. But again, if you can't really convince them of the importance of the research, it's going to be a non-starter, not just at level 1 review in the study section, but especially at level 2 review in the at council, where the program officers vote on funding. Okay, so could you talk more about getting your grant to the correct study section? For our TBI projects, we always ended up at ANIE and really got hammered on the significance in particular. We requested different study sections many times. We're never allowed to move the grant. Okay, so let me address that as well, because that's the other piece of this. So if you are going to a standing study section, first thing you want to do is determine, are you going to a standing study section at the Center for Scientific Review? And the way that you determine that typically is by looking at the NOFO. So if the NOFO requests a letter of intent, that should be submitted 30 days before no later than 30 days before the deadline. That's often an indication that it's going to be reviewed at some sort of ad hoc panel, because the letter of intent is typically used by program staff to set up the review. This might change, of course, because there is some question about whether or not reviews are going to occur within the institutes going forward. It might be that they're going to occur all at CSR. There's been some proposal for that, which is a whole other topic, which I think is a really bad idea, but that's a whole other category. So, assuming that you're going to go to a standing study section at the Center for Scientific Review, the best way to locate an appropriate study section is using the CSR ART tool, Center for Scientific Review Assisted Referral Tool. If you just do an internet search on CSR ART, the tool will pop right up. And what you want to do is load some text into that search engine, typically like a project summary or an Ames page. And similar projects will pop up. Study sections that would be a good fit for you will pop up by matching them to previous projects that went to that study section. But you won't see the previous projects. You'll see the study sections. So it'll yield a hyperlinked list of those study sections. You can click on them. You can read about the study section. You can look at the roster of the study section, which tends to change over in June. So we're probably looking at new rosters at this point in July. And you can look at study sections that are closely related to them. So now let's say that you have identified a study section that you like, but you keep not getting sent to that study section. So there are two things you can do if you keep getting misrouted to what you deem to be the wrong study section. The way that you make a study section request is in the 2-page assignment request form. So you want to make sure that you're not making the request in the cover letter. Make sure that you're making the request in the assignment request form. In addition to being able to make a request for a study section, below that there's an open response box where you can give the rationale for why you're making that request. And within that open response, you can also say why you think a different study section is the wrong one for you to be sent to. And it can't be like, we don't want to be sent to this other study section because we keep getting bad reviews there. It has to be something that is germane to the science. Like, we don't feel that study section is appropriate because they don't have expertise in XYZ, and we really need that to have a fair and impartial review. So if after all of this you are still getting assigned to the wrong study section, you can't get your assignment changed typically. I can't remember an instance where I've ever seen that happen. However, if you see in ERA comments that you have been misrouted, in your opinion, to a different study section, there is still one more thing you can do. You can look at the roster of that study section and you could make a determination of why it is that you think you keep getting bad reviews there. Is there some area of expertise that's missing on the panel? If so, if you can make that case, you could email the SRO and say, we keep getting sent to your study section, and we feel, this is how you want to word it, in order to get a fair and impartial review, we would need XYZ expertise represented on the panel. Are you willing to add that expertise via ad hoc member? You can't ask for a specific person, but you could ask for a type of expertise to be added via ad hoc member. So if all else fails and you keep going to the wrong place, that's one way to try to customize this wrong study section to your application. If you make that request pretty quickly, SROs tend to say yes to it because they can usually add that ad hoc expertise as a phone-in reviewer. So it usually isn't a lot of work or expense for them to add it. So anyway, it's something that you could do. These are the various steps along the way to try to pump the brakes on going to that wrong study section. And hopefully one of those strategies will work. Eric, I hope that was helpful. Okay, let's see. Can I ask for your guidance on how to design the aims for my K99? My current draft is more preclinical, but given the recent news, I'm now planning to keep aims 1 and 2 preclinical and design aim 3 using human samples. Wow, this was actually something that came up with a team member of mine who is on the call right now. A friend of mine, Becky, is on the call, and we were just discussing whether or not this was even allowed on a K99. So first, let's talk about how to design the aims on a phased mechanism, right? So the K99 is a type of a biphasic mechanism. There are all kinds of biphasic mechanisms at NIH, like the R21, R33, R61, R33. In this case, it's the K99 R0/R00. It's a biphasic mechanism. So how does one write aims in general for a biphasic mechanism? So the thing about a biphasic mechanism is that it's not like you land the grant, and as long as you write, competing progress reports every year saying that you're, doing what you're supposed to be doing, what you promised to do, you get the next year of funding. In a biphasic mechanism, there have to be certain milestones that you meet, and there's a go, no go point at the end of the first phase and before the second phase where you might not be allowed to advance if you don't hit those milestones. So you have to clear a hurdle at this point. There's a go, no go point. So the trick in writing those is that you have to make it really clear what those milestones are so that program officers can assess whether you've been successful on the K99 phase before you move on to the R00 phase. And when you write it, you want to make sure which aims are for the K99 and which aim or aims are for the R00. So this is a very typical scenario where there are 3 aims. 2 of them are for the K99 and 1 is for the R00. And actually in the update to Master the R Series Chapter 2 that I just did for the boot camp, I actually included a slide about how to structure biphasic aims pages and various ways to write them, where you could say like K99 aims, aim 1, aim 2, R00 aim 3, or you could say aim 1, parentheses K99, aim 2, parentheses K99, aim 3, parentheses R00, but you have to make very clear which ones are which. So this person is referring to this news about that I have not had a moment to dig into because I'm just hearing about this today, but I promise to have more information about it at the next session, about limiting preclinical models. So I'm going to see again, without having dug into this information, and if anybody has information, please do share it with the group, but in what universe is the pharmaceutical industry going to say that it's okay for NIH never to allow preclinical models to, like, what are we going to do? Like test things in humans and skip preclinical models? Like the FDA isn't going to allow that. Pharmaceutical industries are going to be up in arms. Like I don't know what the wording is of what NIH supposedly is saying about this, but there has not been a notice issued by NIH, and they may be limiting preclinical models, but I can't picture them eliminating them. So, exercise caution in revamping your aims page and the structure of your project in the absence of a conversation with a program officer. I would strongly encourage you to talk to a program officer. So here the person is suggesting that they're planning to keep aims 1 and 2 preclinical and designing aim 3 with using human samples. I will caution people that with a mentored K series, you typically can't lead any kind of clinical trial. So if that's something like, if that's a way that you're trying to get around this preclinical animal model situation, that's typically not going to work. But here the person is proposing human samples. That might be a great way to address this and to try to be responsive to this rumor. And I'm just going to call it a rumor because I've not seen a notice from NIH yet. So yeah, that could work. Again, I would strongly encourage you to have a conversation with your program officer about it, to see if there's anything even to be responsive to. And if so, would this be considered responsive to that supposed change in policy? So speak with the program officer. I hope that was helpful. You probably have answered this question a million times. Would you advise on mechanisms like the R21 to collect preliminary data and to build collaborations for a future R01? I'm specifically looking for non-clinical trial. Thank you. Okay, that's good to know because in the next session, in 2 weeks, we're actually planning on presenting the opposite of that. If you're planning for an R01 funded clinical trial, what are some planning grants you could use for that? And we're going to compare and contrast R34, R21, R61, R33, the different planning mechanisms that you might use. But in this case, the person is specifically looking at a non-trial situation. So an R34 would typically be out in this situation because there is no more apparent R34. And while an R34 is technically a planning grant that would, in theory, help you build collaborations, in my experience, most of the NOFOs are geared toward a clinical trial planning grant. So you might be able to find an R30. There are a lot of R34s that are sponsored by institutes, and you might be able to find one that is not geared toward a future R01 funded clinical trial, where it really is truly a planning grant in its purest sense, where it's helping to establish the collaboration. And that would give you more time and money because most R34s are they're usually 3 years and a cap on 450,000 in directs. But again, most of the NOFOs, in my experience, are geared specifically toward it's usually used as a clinical trial planning grant. So in the absence of that, the R21 could be a good use of that, with the caveat that you are still, yes, it can help you beef up a collaboration, but it's a little tricky, I think, nowadays, despite what the NOFOs say. And the R21, there is a parent announcement, and there's a clinical trial not allowed and a clinical trial required version of it. And there are institute-sponsored R21. So you have two pools to choose from: the parent R21 clinical trial not allowed, and the institute-sponsored ones, which sometimes are topic-specific and sometimes not. But the typical scenario is that it's 2 years and capped at 275 directs on an R21. In most instances, despite what the NOFO says, you're still going to have a somewhat established collaboration in some publications in the field and preliminary data in the field in which you're applying. So you could use it that way. You could also look to other sources. You might have a lot of times, and I don't know, I know where you're from, the person who asked this question, but I don't know if you have this at your institute because I'm not familiar enough with your specific branch of this institute. But I know I have a lot of clients at universities and academic medical centers where they have internal funding that's available to help you establish a collaboration so that you can go in and be more competitive on an R01. In fact, I even have clients where there's internal funding available to help you establish a collaboration to be competitive on an NIH center grant. So I would inquire first about internal funding that might be available to help establish your collaboration and build up your publications. You could also look at private foundations for that. You don't need a lot of money for this, right? Like you're talking like a couple of $100,000 over a couple of years should do the trick to help you establish the collaboration and build up your preliminary data and publications. But yes, you could use the R21 and even the R03 potentially to accomplish that goal, with the proviso that you have to look at the intent of your specific NOFO, because some of them have a specific intent for that NOFO, particularly in a given institute. And again, have a conversation with a program officer at your institute and see if they have anything that is specific for that purpose. So I hope that was helpful, Jen. Okay, from AAMC Medical Research Policy and News, NIH will no longer seek research proposals solely using animal models. Again, this is not NIH. Like nothing has come out of NIH. So this is at a July 7th FDA NIH meeting on reducing animal testing. And I have a copy of the video. If anybody wants it, I can give you a link to the video. Officials from both agencies spoke about plans to reduce, not eliminate, reduce the use of animals in research and to shift to increased use of NAMs or new approach methodologies. Nicole Kleinstroyer, PhD, National Institutes of Health, Acting Deputy Director for Program Coordination, Planning, etc. Quote, all new NIH funding opportunities moving forward should incorporate language on consideration of NAMs. NIH will no longer seek proposals exclusively for animal models. The agency announced in April that it would prioritize human-based research technologies and publicly report on research spending annually to measure progress toward reduction of funding for animal studies. We'll see. There's a difference between a person saying that and an FDA NIH meeting and an actual notice being issued, which has not come out yet. And I don't know what that means. If they say they're reducing the use of animals in research, and then they say we won't see, they're all new funding opportunities moving forward should incorporate language on consideration of NAMs. So maybe the language on consideration of NAMs is it wouldn't work in this instance. We have to use animal models. We're going to continue to use mice or rats or whatever it is. And, of course, there's always been the requirement for language about limiting the use of animals. That's not new, right? So they're going to prioritize human-based research technologies and publicly report on research spending annually. So it's hard to know what to make of this in the absence of an actual official notice. So, you're looking at the same thing I'm looking at. There's a video here. I have not had time to watch it, but a colleague did send it to me, even with a timestamp, about where the language starts. So I am going to drop that in the chat for people. Let's see, chat. And this is courtesy of my colleague Becky, who was kind enough to send this to me about an hour ago. Okay, I just put the video there, and I'm going to say starts at 2 hours 38 minutes 43 seconds. That's what she reports is where the information is. I have not watched this. Greg very helpfully has included the quotes that the person said. But, I don't know what this is going to mean in the absence of a notice or in the absence of NOFOs that have language around this. It might be simply a matter of explaining why you need to continue to use a preclinical model and can't use human samples or, modeling of other types, mathematical modeling or whatever it is. We'll see. I'm always reluctant to fearmonger when information is coming out of this administration, because the initial version of things that come out always seem extraordinarily alarming and then may or may not come to fruition. So I always kind of caution that, let's take a breath. Let's wait and see what the actual information is. It's a very bizarre way to distribute information, official information about policy, which doesn't mean that it isn't going to be some kind of policy going forward. But yeah, we'll see. All right, let me move over to my mail-in question. So this was a comment made on a boot camp survey. So I wanted to address it. This is part of the comment that the person gave, but it's the part I want to address. I have to say that I think the review process is considerably more political and outside influenced than you describe. I don't know that there is much you can do about that, but I think it is important to acknowledge it. So I want to talk about this for a moment, because this is a criticism that has been leveled at the Center for Scientific Review and at NIH in general on their internal review. On and off over the years, I've been I laid eyes on my first R01 sometime around 1988-ish, 87, 88, 89, somewhere in there when I was doing my undergraduate senior thesis on fetal ketonuria. So and I've seen this criticism leveled in various guises at many points in time over the years. And the Center for Scientific Review and NIH have done a number of things over the years to try to address this criticism with varying degrees of success. So the criticism goes that the study sections are, and I'm just going to speak in sweeping generalizations, that the criticism is that the study sections are an old boy network, and that established investigators with multiple R01s are giving favorable reviews to their buddies who are also established investigators with multiple R01s, and that it's really hard for junior faculty or non-traditional underrepresented people to get their applications funded. And like most criticisms like this, it's probably at least partially true, right? And it has been true to varying degrees over the years. So what has NIH done to address this? Well, among the things that they've done is NIH, over the years, various institutes have tried to cap the number of R01s that any given investigator can have as a PI. So, and this seems to come and go. There's, like most things at NIH, the institutes tend to operate as their own little fiefdoms, and there isn't a coordinated policy across all 27 institutes and centers. But over the years, I've seen various institutes issue statements saying that you can't have more than like 2 or 3 R01s as a PI from their institute. It's usually somewhere around there, like 2. And they cap it after that, or they'll say, like we're willing to review it, but it will be we will seriously consider the fact that you're already PI on multiple R01s, and that will be unfavorable for you in terms of whether or not we would give you another one. So there's often some language like that at institutes, and it comes and goes. There doesn't seem to be some coordinated policy. A given institute may have that policy for a couple of years and then it's phased out. Another institute never has the policy. A different institute, maybe they didn't have that policy and all of a sudden it occurs. So it's one of those things that if you're in that situation, you want to check with the program officers to see if there is a policy like that at your institute. Other things that they've done are, this was part of the reason that they launched the Early Career Reviewer Program at the Center for Scientific Review. So the Early Career Reviewer Program is it's a program to try to allow people who are very early. Standing study sections are usually people who are well established in their careers. They're invited to serve 12 non-consecutive sessions at a standing study section. The Early Career Reviewer Program is a one-off where somebody who is junior faculty is invited to serve a single session of a study section. And it gives them a sense of what that process is like, and it also brings somebody who's more junior into the mix. So, and I've talked about this program quite a bit, but if anybody is interested in this, just do an internet search on Early Career Reviewer Program, ECR, and it'll pop right up. And I think you have to be, in your faculty position for 1 or 2 years, something like that. And you have to have submitted an NIH application and gotten the summary statements, but not been funded, or not served as an PI on an R01 yet. And there are, various requirements in terms of publications, how many publications you have as first author and what time period. But anyway, the whole point is to get junior people in there. And part of the reason that CSR is keen on doing that is that there's a lot more diversity at the junior faculty level than there is at the full professor, more senior faculty level, which tends to be a much more homogeneous group that is largely white and male. Junior faculty tends to be more diverse on every level, like socioeconomically, racially, ethnic, gender. There just tends to be more diversity at that level. So the idea is that bringing ECRs in there, the early career reviewers in there, will add those voices to the mix at study section. There's also been some effort on CSR over the years, at least they've paid lip service to it, to bring in people who are more junior and not always be having the more senior people serving the study sections. There's also been discussion of doing anonymous review at CSR. This is something that has gone in, this discussion has gone in and out of favor over the years. And the idea would be that you would remove you would assess the science. So it would be like factor 1 and factor 2 in the new simplified scoring criteria. You would assess that divorced from your assessment of the investigator and the environment, which is factor 3. And the thinking is that may help eliminate some of this bias, if you will. So, but having said that, I still do hear from some people, both reviewers and applicants, that they feel that the process is political, and not just in terms of, like their reviewers are established reviewers with multiple R01s are giving favorable reviews to their cronies, and that there's less there's more taken on faith attitude in terms of reviewing those applications, as opposed to junior faculty where there's a credibility issue and they're unknown. I also hear of people complaining that program officers tend to sometimes favor people who are known quantities to them, and that, all else being equal, if scores are clustering around the funding line, that a given program officer might be more inclined to pitch a funding pitch at council for somebody they know, for somebody they've worked with, for somebody who's been a successful R01 applicant. And like most things, that's probably at least partially true. So there is some element of this that is probably political and probably out of your control. And it is something that is discussed quite a bit among NIH and CSR circles about how to address that and how to at least reduce that kind of bias. So anyway, that's just something that I wanted to talk about because I thought it was a really compelling comment and worth exploring a little more deeply. So I don't know who made the comment. It was anonymous, but I appreciate you weighing in, and hopefully that is helpful for you guys for whatever it's worth. So we have a couple of minutes. I don't know if anybody has any other questions. I don't see any questions in the Q&A. So I'll stay on for another minute or two. I'll remind people that our next session in 2 weeks is on the 23rd of July. It's a Wednesday, of course. And that is at 3 p.m. Eastern time. And we'll be, my colleague Becky and I will be exploring clinical trial planning grants. So what are the types of mechanisms you can consider when you're planning for a future R01 application to fund a full-scale trial? So you're interested in funding the full-scale trial at the R01 level, and why you might choose an R34 or an R21 or an R61 R33 or an R21 R33 or a standalone R61 or a standalone R33, and what the differences are among those things and what you should be considering with those. Our next First Fridays is August 1st, so that's open office hours. And if you're not registered for that, just email us and we'll help you get registered. So meg@bouviergrant.com. And again, if anybody has used our membership and felt that it helped them land an NIH grant, we'd love to hear from you. So drop us an email. Okay, we have one last question here. I am a clinician, but not actively practicing and performing clinical research. Would a K-23 be an ideal grant to apply for from a competitiveness standpoint? That's a really good question. I'd have to read the NOFO because I'm having trouble remembering a scenario where I had a non-practicing clinician who applied for a K-23. If anybody has any experience with this, let me know. But and of course there are like different K-23 NOFOs, so you'd have to look at them carefully. But I would read the NOFO carefully and contact the program officer, even just by email, and just lay that out. I'm not actively practicing and performing clinical research. Yeah, it's hard for me to imagine, like, you're going to have preliminary data. So if you're not actively performing clinical research, are you performing what are you doing any research? Anyway, as always, I'm going to suggest read the NOFO really carefully and contact the program officer to check out your eligibility for a specific K-23 NOFO. So, all right. So I am performing clinical research, but not practicing medicine. Oh, yeah, then you're okay. That's okay then. Yeah, you could do that. Your considerations would probably be yeah. I would look at the K-23, but usually if you're a clinician, you look at the K-08 or the K-23. Those are typically the two that you would look at. But in this instance, it's probably the K-23. But again, read your specific NOFO. You probably have a target institute in mind, and I would see what active K-23 NOFOs they have. Sometimes they participate in the parent announcement, and sometimes they have their own institute-sponsored one. And I'd read the eligibility requirements really carefully and have a conversation with the program officer about it to make sure that you're eligible. But yeah, clinicians usually steer toward K-08, K-23, one of those two. So, okay. And we're just about out of time. So thank you everybody for attending. Again, if you are interested in attending First Fridays on August 1st and you're not registered, just drop me an email, meg@bouviergrant.com. We'll help you get registered. And I hope to see some of you back here in 2 weeks for a conversation about the different types of NIH clinical trial planning grants and why you might choose one over another. And thank you everybody for attending. And as the French would say, courage. And I wish you the very best of luck. And I'll see you in a couple of weeks. Have a great day, everybody. Bye-bye.